Hi, I'm Dr. Robert Nucci from Nucci Medical. I'm a orthopedic spine surgeon that's been practicing here in Tampa Bay for the last 25 years or so. We're here in our little sound studio with our new green screen behind us. So as you can see, the Aurora Borealis behind us. So that's what that is. I wanted to talk today about a technique which we developed and perfected here at Nucci Medical. But I wanted to give you a bit of a history, a little bit different this time than all lectures and webinars I've given before, of how we sort of got to this technique by using the history of Nucci Medical and Surgeons Park Surgery Center, which is our surgical center that's built next door, how that all really occurred. It goes back really to our patients, what they were asking of us. My practice from very early on was dealing with patients who were injured, no fault of their own, fall, car accident, whatever, work accident, and were in good health overall, prior, and then were injured and couldn't work. They weren't making a living. They had financial problems and so on, and they came to me for help on their spine. Now, as a spinal surgeon, the way I was trained, we were trained in certain techniques. And those techniques often were inpatient techniques, open techniques, techniques that required hospital stays, and techniques that worked very well for spinal injuries, but were slow recovery. So patients took time to recover. And it was a big burden on our patients to have this kind of downtime. They really couldn't afford it, literally couldn't afford it. So over the years, we've tried to figure out ways to do techniques which were as effective and often more effective than the traditional ones one was trained on, I was trained on, and people are still trained on, in order to get people back to work quickly. Now, this is 25 years ago. Nowadays, outpatient, getting back to work quickly is something that everyone talks about. But 25 years ago, they really didn't talk about that. They talked more about inpatient procedures. But in my patient population, I really needed to get them back to work. I needed to get them back to their life. I couldn't do these larger techniques that put them down for any length of time. So over the years, we've developed techniques that have done that. The technique of which I'm going to talk about today also addresses that. We developed this in response to what our patients were presenting with. The technique that we're going to discuss is a pretty much permanent solution, or a permanent solution to a problem which is very common, and to which there is no, as it stands now, no good long-term solution. So we're going to discuss something called, there's no good name for this. We use the CPT book because it's actually an old technique that's an open technique from years ago, which we perfected and now do it with a minimally invasive procedure, small little tube and so on. I'll show you that in a minute. But the codes for that technique are old, but the technique has been perfected by us over time. What we're trying to treat is something that is common after a fall or after an accident, and that's something called facet pain. The older way of treating it was actually the way people treat it now pretty much is with a radiofrequency technique, and we've developed a laser technique, which we'll discuss the difference in a little bit. But from a high level, the radiofrequency technique, which is an extremely common technique for treating spine pain in the United States and worldwide, is temporary, and people have to have it redone and redone. And the laser technique, which we've developed and perfected, is permanent, so it's a one-time deal. And again, this goes back to the history of Nucci Medical. I can't have my patients have to come back for the procedure every 6 months to a year to 18 months. They can't afford it. They can't have the downtime. And many times it just isn't possible. So they get a technique that works, and then it comes back, and then they're stuck with it. So in response to our patients' needs, we developed the technique. And that's really how most things have developed here, even the surgery center next door. That was developed because we wanted control over what happens in the operating room. So we wanted the right people who are trained, the right equipment, In the hospital setting, often you don't know who you're going to get in the operating room, frankly, and that's not good. So we wanted to control as many things as possible to make sure our patients got the best possible care and get the best results with the at least variability when they're in the operating room. So that's how the surgery center developed. So that's been a continuing theme of Nucci Medical for years and years, and this technique is just the next thing in that. And I'm happy to say, when we started this now 5, 6, maybe 7 years ago, it was just us who were doing this. Nobody else was really doing it. Now it's starting to catch on. Trained a few people on how to do it, but it's catching on, at least in the low back. And we do this throughout the entire spine, which again is unique. So I think we're breaking new ground here. We have broken new ground, and we've had great success. So I want to share that with you today. So let's go through the talk now that I've given that sort of background of things. Okay, we'll go to our next slide, please. All right. All right. Well, one of the things that one should understand when dealing with patients with low back pain, and what I'm talking about is back pain from somebody who has an injury. Most times people get an injury, their low back hurts, their neck hurts. It goes away in a couple of weeks, but sometimes it's persistent. And when the patient comes in to see us, there's essentially 5 causes of low back pain, which are the common causes. There's some esoteric things, but generally you're dealing with 5 things after an injury or an accident. One is, as most people would realize, muscular pain. Well, there's a lot of muscles in the neck. There's a lot of muscles in the back. We're talking about low back right here, but a lot of muscles in the low back, and they can be injured. And that's often the case. So that's one thing we look at. Another thing that we look at is a discogenic pain, disc herniation pain. And this is commonly a common thought that this is the injury. Patients come in, have an MRI, they have an MRI disc herniation that's read by the radiologist. And even on my read, when I look at the films myself, I may say, oh, yeah, you got a herniation. But it's usually not the cause of low back pain. It's sometimes a contributor, but it's rarely the main thing. Can be, but rarely. But it is a cause, and we have to take that as a possible cause when we're examining patients. The third reason people get low back pain is one that has been up until maybe 5, 7 years ago, either completely disregarded or completely misunderstood, and that's sacroiliac joint pain. And we'll talk a little bit about sacroiliac joint pain too, but I'll give a brief background here. Sacroiliac joint pain, when I go back to my old textbooks, my father was an orthopedic surgeon, go back to his old textbooks, routinely they would say sacroiliac joints are stable, it's rarely cause back pain, and sort of basically gonna forget about it. And that is untrue. It is a very common cause of low back pain. The sacroiliac joints are the joints that connect the spine to the pelvis. And I actually have a little model here. If I can show it or not. Well, let's see here. This is the pelvis, as one would know. This is the front, if you're looking at the front of a person. Here's the sacrum, that's the lowest, essentially vertebral body in the spine. And between the spine, which would continue up to the pelvis, there are these joints, sacroiliac joints. They're fairly large joints, and from the back, you can't see them quite as well. They're hidden behind the pelvic brim here. But they're joints that connect the spine to the pelvis. Maybe looking down on it, you can see it here. Here's your pelvis, and here are your sacroiliac joints. So it connects the two of them together. Now, they're very stable joints, very, very stable joints. They got ligaments in the front and the back, but they can be injured. And they can cause back pain, usually one-sided back pain, or it could be both sides if it's both sacroiliac joints. Very common, often misunderstood. Another common cause of back pain, number 4, is one that I'm sorry to say many spine surgeons have overlooked in the past. And fortunately, as an orthopedic surgeon also, we examine the joints. And hip pain is a common cause of low back pain also. So during an exam, you may have to make sure the hips aren't a problem or a contributing problem. I've had patients who've been operated on and they come in and they still have pain. It turns out they need a hip replacement. So we don't want to make those kinds of errors. I didn't make that error, but we don't make those kinds of errors. And so we got to make sure we examine the hips. And the 5th one is facet pain. And that's the one we're going to sort of focus on mostly today. Now, facet pain is arguably the most common cause of low back pain after an acute accident for patients who don't get better. Now, the facet joints are little joints that go all the way up the spine on both sides. There's one on each side. They're like little finger joints allowing you to bend and move. And I have another model here. Here's a model of the spine again. This one doesn't have the pelvis attached. These are the vertebral bodies. Let me get my pen out again. These are the vertebral bodies, these bones, in between the discs, which are the cushions. Again, we're looking at the front of the spine. All right, we turn around like that. Now we're looking at the back of the spine. Here's that sacrum again we saw earlier. And these things are the facet joints. There's one on each side. They go right up the spine. And maybe if I turn, you can see they'll move, right? They move as the spine bends and moves. These little joints will move. Those are the facet joints. They also allow some twisting of the spine also. And they're commonly injured in the back. And I would say probably the most common injury, maybe secondary muscle for subacute low back pain. Subacute low back, maybe back pain doesn't get better in about 3 months or so. That's subacute low back pain. I'll take our next slide. Now, neck pain, that's a different. I tell patients the neck and the back are different animals. You know, what works in the neck may not work in the back. They're really different things, and we got to treat them, and we treat them differently. Well, there are 4 causes generally of neck pain from a subacute neck pain from an accident. One is, again, muscular pain. There's lots of muscles in the neck, and they're injured, and that's very, very common. Second, again, just like the low back is, discogenic pain. Again, disc herniation pain, disc injury pain, disc arthritis pain. Again, not really that common cause, not very common cause of neck pain. And another lecture, maybe we can talk about how discs injure nerves and how you can get arm pain and so on and leg pain. But we're talking about neck and back pain today. So as a primary cause of neck pain, disc herniations, not common. Again, patients come in with MRIs. Oh my gosh, I got a herniation. It's probably not symptomatic, and it's almost always not surgical. But it is a cause. Third one is shoulder pain. People have shoulder pain and it radiates to their neck, and frankly, vice versa. So they come in with neck pain, but actually turns out it's a shoulder injury or also a shoulder injury. And the fourth one is, again, facet pain in the neck also. Those little joints allowing you to bend and move, and these facet joints in the back are often injured in an accident. Next slide, please. All right, so we talked a little bit of subacute low back pain and neck pain. What's the difference? Well, let's go into it a little bit again. Acute, it happened, right? Here it is. It happened today, and there it is. So usually acute neck pain, acute low back pain improves within a couple of weeks. 6 weeks, it really should be significantly improved or completely resolved. Things get better on their own. And quite frankly, not much treatment is needed. We want to make sure patients move, they don't get stiff, they learn how to stretch. Occasionally, we give them some non-addicting medicines, but they almost always improve. We don't intervene with very much at that point. However, sometimes they don't get better and they become subacute, which means after 6 weeks. The goal really is to not have it become chronic. Chronic pain is better understood today than it was years ago. And in the past, we said chronic pain, oh, it's there a long time, it's chronic pain. Well, that's not exactly right. It is there a long time, but chronic pain actually has an additional meaning. There's some physiological changes that occur when you become chronic. Chronic is debatable, let's say between 3 months and 6 months. 6 months is probably a good bet to say chronic pain. After 6 months, for neck and back, you may be moving into a chronic pain situation. We're actually dealing with physiological changes in the central nervous system, the brain and spinal cord. Very difficult to treat that kind of thing. So we don't want that to happen. We want to not treat acute pain too aggressively. We want to deal with subacute pain and do what we need to do to get better as quickly and easily as possible. But we don't want it to go to chronic pain. That's the difference. Okay, next slide here. We talked a little bit about this here. The animation there shows those joints moving better than I showed in my little model. But you can see the joints on the video there on the upper right or the right of the screen there, those joints moving. So the facet joints are very much, as I said, like finger joints. They are like knee joint. The cartilage in that joint is the same, not basically the same, it is the same as the cartilage in your knee or in your fingers and so on. And the ligaments that hold it are similar to the ligaments that hold your knee and fingers in place. So those are your facet joints. Now, this is an area that I think is often misunderstood, particularly by patients, and I think some physicians too. The facet joints, excuse me, have a sensory nerve supply. In other words, if they're injured, they hurt. And they hurt because a sensory nerve goes to the area of the joints. Truth be told, there's the way the anatomy is. The nerves come out of the spine on the sides. It shows there in the picture. Maybe I'll show it with the model again. We don't have the nerves here, but the nerves come out the holes on the sides, called neuroforamen. Neuro being nervous system, foramen meaning hole, so neuroforamen. So the nerve comes out, but branches of those nerves, branches off those nerves go to the facet joints, some sensory branches, and one of them is the medial branch. So a medial branch nerve goes to the facet joints, one from the nerve above, one from the nerve below, goes to the facet joint and gives sensation to that facet joint. So if you injure your joint, it would hurt, and the median nerve, branch nerve, is the reason it would hurt. It's purely a sensory nerve, not a motor nerve. It doesn't make the joint move. Now, what the slide mentions is something called peripheral sensitization. Now, when you injure your joint in an accident or your joint is injured, as I said, it often gets better. But sometimes there is continued pain. Now, what is going on, generally going on, is the joint itself is healing fine, but the sensory nerve that goes to the joint becomes sensitized. In other words, it becomes painful and is active even if the inflammation around the joint is decreased. So it's acting as if there's pain, it's firing, it's aggravated, even though the joint may not be stimulating it, it's stimulating itself on its own. It's called peripheral sensitization, something we've come to understand much better as time goes on. And it seems, and it can happen to any nerve. It can happen to the nerves in the knee, for example. One of the treatments for knee pain from arthritis is to treat one of the nerves, small sensory nerves that go to the knee, because it's hypersensitive, it's hyperfiring, it's active. You decrease the activity of that little nerve, or nerves, and the knee pain improves, even though the arthritis is still there. So we become aware of this peripheral sensitization of sensory nerves. It seems that the further you get away from the spine, the less likely it's to occur. So it doesn't happen that much in the ankle, happens more in the knee. It certainly happens to these facet joints in the spine. Now, we're going to talk a little bit about medial branch blocks, and people are always asking, what is medial branch blocks? Well, you're blocking the median nerve because you're trying to see if this peripheral sensitization has occurred, and if it has, what to do about it. We'll go to the next slide. First thing we do after talking to a patient, of course, is do a physical examination and make a diagnosis. So let's go through that now. All right. Now, facet pain is one of the causes of low back pain. Unfortunately, things aren't very simple on examination. Pain overlies one another. For example, the area of your joint would hurt from facet pain is an area your muscle would hurt, which maybe an area your circulatory joint would hurt. So all these areas cross over one another, and it's difficult sometimes to figure out where, well, the patient is pointing to pain here, but is it from this joint? Is it from the circulatory joint? Is it from the muscle? Is it from the hip? They all sort of radiate pain to the same direction. In general, they're slightly different, but they overlap a lot. So there's some tests we use to try to make sure that we understand the cause of the pain, that it's not one of the other causes, but it's facet pain. So one of the things we ask patients to do is extend their neck, extend their back. I'll use the model again. When you extend, and it's an extension, you stress the joints. You're stressing the joints. Flexion is relieves pressure on the joints more than extension. So if somebody extends their back and they have pain and spasm over the joints of the back, which are deep, but you can still feel the area of the joint, they probably have facet pain. That is one of the exams. Next slide, please. Now, examination is good. Now, we often, most of the time, almost all the time, make the correct diagnosis, appropriate diagnosis by examination. Now, one of the things I said before is the different causes of pain. Now, back pain and neck pain. Well, you don't necessarily have to have one cause. You can have two, you can have three, you can have four. You can have all of them. You can have 5 in the low back and more. So what's the cause? Let's say you do have an exam that shows facet pain. and or you think it shows facet pain on your exam. But maybe there's these other causes too. We're not sure. Well, we want to know what's the biggest cause, the main cause. We like to isolate pain down to one or two main causes so we can specifically treat them. So one of the ways we do this is confirming our diagnostic exam concerns or exam diagnosis of facet pain with something called a medial branch block. Now, we talked about this a bit earlier. We're numbing the median nerve, that nerve that becomes sensitized. It's hard for me even to say it. Patients can't ever say it, but it's hard to say. Anyway, that nerve that's sensitized is active, and we want to block that nerve. So we put some numbing medicine on that median branch nerve, and the patient should be pain-free immediately. So the pain should be gone. So if indeed it's facet pain from that median nerve being hypersensitive, then the pain should go away immediately. We'll talk a little bit about the difference between a medial branch block and a facet injection in just a second. But that's what you're doing. You're confirming it. So the patient says, hey, my pain went away. Then we figured it out. Hey, my pain went away 70%. Well, then 70% is from that, and 30% is presumably from one of the other causes of neck or back pain. Next slide, please. Now, facet injections are injections into the joint themselves. The medial branch block is injection to the nerve that goes to the joint. They're both very good. There's always a debate which one's better. I prefer at this time the medial branch block because we're actually going at the nerve that's acting abnormally. Facet injection will work too because it numbs the nerve as it gets into the joint itself. But since you're going to be treating the median branch, I think you should probably inject the median branch, because if that's what you're going to treat with laser or radiofrequency, which we'll get to, that's what you should be injecting. But it is a bit of a debate. One's better than the other. I tend to like to treat the ones that I'm diagnosing rather than inject something else. But that's a personal opinion that's shared by many others. Next slide, please. Okay, so you've had your medial branch block now, and now you've gotten relief of your pain. Great, so what's the next step? What do we do now? Now we know those joints are irritated, that nerve is hypersensitive, is hypersensitive, let's just go with that. Hypersensitive at one or more levels. Let's go to the next slide. All right, now that you've made that diagnosis, that median branch nerve at one of the joints, because it can be more than one, often is. Let me go to the model again. It could be this joint and this joint and this joint and this joint. It could be three of them, and it could be more than one. So now you've made that diagnosis. Great, what do you do? Well, there are essentially two ways to go with this as we sit here today. One is radiofrequency ablation, which is a technique that's been around a long time. It is probably the most common treatment for back pain out there. It's very, very common, way more common than surgical intervention. And another technique, which is laser-assisted nerve transection, which we call LANT. That's our name for this. In the code book, it's got a long diet. It's a long. Maybe I'll tell you about it later, but we call it laser-assisted nerve transection. Let's go into the differences. Now, with radiofrequency, and that video is showing it, you're taking essentially a hot probe and going down there and burning the nerve. So you see there, the nerve sort of gets burnt. And when a nerve gets burnt, it doesn't work very well anymore. And the pain resolves because now that nerve is sort of dead, right? But you can even see in the picture, the nerve is still intact. So it's like, the analogy is reversed, and I'll tell you why in a second. But it's like having a wire. You take the insulation off the wire, it doesn't really work anymore. You put the insulation back, it does. Well, that's sort of what's going on here in a way. You burn the nerve and it doesn't work, but the nerve grows back and then the pain returns. That can happen anywhere from 6 months to 18 months. So let's say around a year. So you got to have it repeated again and again and again and again. As I mentioned earlier, it certainly goes against the philosophy of practice, or it rubs the surgeon the wrong way. He doesn't like to have to go back and do things again and again. And our patients just really couldn't tolerate that from the lifestyle standpoint and the financial standpoint. So we really need to come up with a better way to do it. But going back to radiofrequency, when you burn the nerve, you can think of a nerve as like a wire, and you got the wire inside, the insulation on the outside. When you burn a nerve, what happens is actually the nerve inside the insulation, the perineurium, inside the insulation, dies. It gets burnt. the outside remains. And so the nerve endings find each other again and the pain returns. So you got to do it again and again and again and again and again. So that's radiofrequency. We've done it. I've done it. Works very well. It just comes back. And that is just not tolerable for my patient population, really for anyone who doesn't want to be coming back. Now, laser-assisted nerve transection, and that's not exactly how it goes with that, but you can sort of get the idea. It is actually a laser. And I really tell patients, laser sounds, high-tech and cool. It is high-tech, and it is cool, but it's not the laser that's the important thing. It's the transection that's the important thing. Now, the laser is a tool that makes the transection be able to be done with a very small incision and a very focused way. So you don't have to make a bigger incision. I talked to you a little bit about this. The technique has sort of been around for a long time, and it has. People have been transecting the median nerve for a very long time. It's not a super common technique now because people use radiofrequency, but that is a technique that exists. It's been around a while. It's in the books and so on. But to do it, you have to dissect down. You make an incision, find your way down and cut the nerve, and cut the ends of the nerve, and that's it. But with a laser, you can do it through a tube, and we've developed some tubes. This is one that's not the one we developed, but it's similar. It's a tube. Basically, you're putting your laser through the end of the tube down to the area of the spine. So maybe I'll lose my model again. So for the small skin incision, you can see how tiny that is. Go through the skin down to the area of the medial branch, which would be here, your joint being here. And then you would use the laser to transect that median nerve, which now you are at. The laser is a way to transect the nerve without a lot of blood loss and, frankly, very much pain. This is not a painful procedure. And then the ends don't find each other. The perineurum and the nerve transected. It's not painful to transect this. It's a nerve is already painful. Once it's transected, it doesn't work anymore. It's like the burning. It's just now not working. It's not like the burning. It's transecting, but the effect is the same. It's no longer working. But now the ends can't find each other anymore, and you're not going to have it recur over 6 months, to 18 months. Now, I will mention, and this is not the topic today, but you can use this for the sacroiliac joint. I'll just go through it briefly. There are nerves to the sacroiliac joint. It's not one. There's like the sacrum is actually the spine fused together, genetically fused together. So you have nerves at multiple levels here, and you just transect each one of them, 1, 2, 3, 4 kind of thing. 1, 2, 3, 4 here, rather than just one nerve with the facet. You have 4 of them here, and you transect those. So you can use it for sacroiliac joint pain also, and then that is diagnosed by a sacroiliac joint injection. Sort of a similar idea, or a very similar idea. Our next slide. Okay, here we go. All right. So what's one versus the other? They both work, and I've done both, and they both work. It's just one's temporary, one's permanent. That's really what it comes down to. That's the difference. And in the end, obviously, it's more effective to have something permanent. It's less expensive ultimately. It's easier on patients. It's easier on their lifestyle, on and on and on. So we really do not do radiofrequency anymore. Now, you develop different instruments in different parts of the spine. The low back has certain ones, but we can do this in the mid-back, which does happen. You have mid-back joint pain. As I said, those joints, facet joints, go up both sides to the neck, and in the neck, all the way up to the base of the skull. So that's unique. That one hasn't quite, caught on yet, but we were able to work with some of my colleagues and create the exact right protocol to be able to do it anywhere and everywhere in the neck and low back and sacrum. Next slide. Now, there's our surgery center and our clinic. I think it might be another picture. Our clinic. As I said before, we want to control as much as we can. We don't leave things up to chance. I don't want to walk into the operating room as a surgeon and so is not there that you always work with, or is a different anesthesiologist. It's minimal variability. I always say the only variability should be the patient. That's it. Everything else should be the same. Patients are unique, and they are the unique thing. The surgery should not be unique by having different people in the room or different instruments or whatever. So Certified Surgery Center was developed for that reason. It was not something what we sat around and said we just want to make one. we decided that in order to really get our patients better as quickly as possible, as safely as possible, we just needed to make that investment. And we have. And we run that. That's not run by anyone else. That's run by us, by me and us. The royal us do that. So we all work on that. And let's see. Now, I'll talk a little bit about chronic pain here, because I think it's important to understand that a little bit. Now, we talked a little about peripheral sensitization. I can pronounce it better when I can see it on the screen. There's also something called central sensitization. It's different, and it's very hard to treat. Now, we're treating that peripheral sensitization with the laser procedure and so on. Central sensitization is when it's there for a longer period of time, and the brain and spinal cord and central nervous system is physiologically changed to become essentially accustomed to the pain. And it's a different mapping of the brain. Now, what I try to explain to patients as it's sort of like post-traumatic stress disorder. You know, you have some terrible thing happen, a car accident, or God forbid, a war, or just, you know, it's terrible. And you relive that later on. There's no war going on, there's no car accident going on, but you have to relive that experience in many different ways. So you sort of have an imprinted memory of that trauma without the trauma actually occurring at that time. It's something like that when you have chronic pain. You have the pain imprinted on your central nervous system. So you start feeling pain even when there isn't pain being felt, or the problem is gone. You have an injury and the injury is fixed, but you still feel pain in the area. Peripheral central sensitization also makes it challenging for physicians to figure it out, because peripheral sensitization or peripheral nerves follow a course, right? You're injured in this nerve, it may hurt in a certain part of your hand or a certain part of your leg because the nerve goes there and that nerve is injured, and it's easy to figure out. Central sensitization is not, because the brain is mapped differently. I mentioned that a bit earlier, alluded to it earlier. It's mapped differently. So you can have chronic pain where the pain's in the right hand, the left hand, it's coming out the side of your head, and it's bizarre, and at least bizarre to physicians, and they're like, this person, I don't know what's going on with them. It can't possibly be, they can't possibly have that. Well, they do have it. You know, it is true, but it's brain mapped. It's not peripherally mapped. So when it becomes brain mapped and you have these kinds of pains in different places, and you have you know, pain when pain might not even be there, and even worse, you may feel pain more when pain is there, it's very hard to treat. There's no surgery that can treat that. It can't fix your spine or your injury and now you'll be better, because that's not where the problem is. The problem is in your physiology, your central nervous system. There's some drugs people have tried, medications, I should say, and other treatments, biofeedback. But the best way to treat it is not have it happen, basically. So, you know, you just have to be aware of it and recognize early subacute pain, treat it if it needs to be treated. And sometimes just an injection is enough. I didn't mention that. Some of you injection, you don't need to do anything else. But often you need the secondary laser or radiofrequency procedure where you're dealing with the facet pain. But don't let it get to be chronic. Don't get there, because it's very, very, very difficult to treat. And I will go another little quick aside. I study a lot of things nationally, internationally, in courses and so on. They were doing some lecture on it was European society, and they were talking about back pain and so on and so forth. And they watched a person go from acute to subacute to chronic pain over the course of a year. I just watched it. Now, that was not the point of the video. The point of the video was something else. But the people in the video who were doing the lecture didn't recognize the problem. They were calling back pain non-specific. There's another pet peeve of mine. I'll go on another aside here. Non-specific low back pain means you don't know what it is. I don't know what it is. Could be this, could be that. One of the 8 causes, or 4 causes, 5 causes. We don't know what it is. But after 6 weeks, you need to be specific. You need to figure it out. There's other tests for those other causes that we didn't go into. You need to figure it out. And then once you figure it out, you need to treat it. If you don't, you go into chronic pain. And that's exactly what happened to this woman in the video. She went from diagnosed non-specific, they let it sort of go, therapy forever. for months and months and months. She went on to subacute, she went on to chronic, and now untreatable. Don't let it happen. Get the right diagnosis. So that's a little side on central sensitization. It's just a bad thing. You don't want it to happen. Our next slide, please. And there we are in the operating room with my associate, Dr. Grisales, who I have to give credit to. He also helped develop this technique and has been absolutely instrumental and does it really all the time. He's the laser master. He's there on the right, and I am on the left there in our clinic there. So that's laser-assisted neurotransaction. That's facet pain. A little aside on sacroiliac joint pain, a little aside on chronic pain, but I think you need to see the entire picture in order to really understand what we're trying to do. And the philosophy here, here at Nucci Medical, to try to address the concerns of the patient. Get back to work. I don't want to see you ever again. I love you, but I don't want to see you again. And we love our patients, but we want them to go back to their life and maybe just come in and say hi to us and tell us how great they're doing. That's the lecture for today. It's Dr. Nucci from Nucci Medical. And I know we have some people online here who might have questions, and I'm happy to answer those. I see that everyone has got it all in their head. They all know now. They can go out and preach the joys of laser surgery for the population, and hopefully it will catch on even more as we teach more surgeons how to do this technique. Dr. Nucci, have a good day.